Kia ora tātou, ngā mihi nui kia koutou. Welcome and thank you so much for coming along at this hour on a Wednesday night to participate in this Community Health Council People's Caucus. So we're expecting a few more people may arrive, but because we have quite a time limited 1 hour with you, we'd like to start on time, and our apologies for people who may come in and join us as their work concludes and they can get here with us today. I see a number of familiar faces in the room. What we're going to do in the beginning is to just briefly introduce the council and talk a little bit about what we do. And then we're going to move to focus on the engagement framework that we came and met with you last November about, some of you in the room at least, and to talk about the roadmap and the process for commencing this quite big program of communities, whānau and patients engaging in health improvement throughout the Southern Health System. So Charlotte, have you got control of the slides? Or okay, so we're going to provide an overview of the framework that we've developed and modified following the feedback from our last meeting with you, then talk about what are and can advisors bring to the table and what we're asking you to do in terms of taking back this message to your communities and groups that you're involved with, and then to look at lastly how the Community Health Council can help. So this is an overview of the Community Health Council. In attendance at this committee meeting was Nigel Miller, the Chief Medical Officer, and Emily, who's out there ushering people in. But in the front row we have here Matt Matahari from Dunedin, who's an Ngāi Tahu iwi governance representative, Rosa Flaherty, who gives her apologies tonight. She's actually unwell herself and isn't able to be here. Also from Dunedin, Paula Waby and her guide dog Rana from Dunedin, Leslie Gray, who is from Invercargill, Kelly Takarua from Tapanui, Charlotte, who is the DHB facilitator to the Community Health Council, Hana Halalele from Oamaru, Martin Burke from Dunedin, Bronnie Grant from inland from Gore, myself, Ilka Fedor from Dunedin, and Jason Searle from Cromwell. So those are the members of the Community Health Council currently. And on the next slide, we just talk a little bit about the work, our role really. So we were established with support from the Southern DHB and the Well South Primary Health Network, or PHO, to be an advisory council to the Southern Health System. So thinking beyond the boundaries of the hospitals out into the community, to provide a voice for communities, whānau and patients to work with governance and management teams to develop meaningful partnerships in the design and functioning of an effective healthcare system. And at this point, I think it's just helpful to talk a bit about what we're not. So we are lay community members in very much an advisory role. We don't have a governance role within the DHB or PHO. We're not a board. We're not the commissioners. We're very much members from communities advising the DHB and PHO. And on the next slide. I'm embarrassed to say we're slightly hard to find in terms of our communications. At the moment, information about the Community Health Council can be found on the Southern District Health Board website. So if you go to the website and there's this orange tab at the top left that's about the Southern DHB, and on next slide, that takes you to this page, and where this one here, the Community Health Council, if you click on that link, it takes you to information about the council with key messages from our meetings and various pieces of information about the work that we're doing. So we're a little bit hard to find, and I think one of the big pieces of work for the council is around communication and messaging out to wider communities. So I just want to talk a little bit about some of the types of activities the Council have been involved in their first year. So we actually formed February last year, so it's just been a year and a little bit that we've been going. And one of the big pieces of work that we've been involved with is the development of the Community Whānau and Patient Engagement Framework and Roadmap. We've also had Bronnie Grant from Gore was on the steering group for the Primary and Community Care Strategy and Action Plan, and I'm sure a number of you will have attended those meetings that were undertaken by the DHB and PHO throughout the region around this new model, this new way that has been proposed to redesign our healthcare system. It's quite a substantial change in the way things are done in our healthcare system in the southern DHB. The goal is to provide services much closer to people in their communities. It's a very big piece of work, and hopefully a number of you have been following that. Actually, if you go to the DHB website, you can search for Primary and Community Care Strategy and Action Plan and find very detailed reports about what's being proposed. Hello. We've been involved in the website development. So Paula Waby, who's going to be joining us tonight, is on the steering group looking at improving the website. So that's quite an important piece of work, and wants that website to be genuinely accessible for a wide range of people. So Paula herself is blind, so the information on websites need to be easily navigable by a whole range of people. We've been doing a lot trying to understand the feedback mechanisms and how that works within the Southern DHB. And so I know we've got members from that team here tonight, but we've been trying to look at how we can communicate the importance of giving feedback, be that positive or not so positive, to the wider public, and having people feel more comfortable and able to give that feedback. Sometimes it feels like a really big barrier. It's a really difficult thing to think about writing a letter about what worked well or didn't, and I know a number of you are very, very good at that, but I know a lot of people in our communities are really reticent about coming forward with their ideas for improvement, and we'd really like to support people in that process. Another big piece of work on our horizon is the Disability Action Plan, and that is due for completion by the end of the next financial year. So by end of June next year, the Disability Action Plan should be in place. Now, Paula, Martin Burke and myself are very much involved in calling for that. We've been repeatedly calling for this work to start, and there's commitment from the DHB to do that, which is excellent. Another really important piece of work has been the patient stories. Now on that, I don't know if I can go back, but there's a link on that homepage to one of those patient stories. If you haven't seen those already, I really encourage you to go in and look at those stories. So these are stories that are recorded that describe people's experiences and challenges that they might have faced in the health system. And there are more calls for, if you have a story yourself, or you know of other people who would like to be involved in sharing their story, you could notify Charlotte and we could put you in touch with the people who are recording those. Now, some stories are kept for training purposes. The stories that are publicly available, the people have themselves said they're happy and would like that to happen. So there's various levels. You could say, I want to tell my story, but it's for training for staff only, or it could be available more widely.
Just out of interest, how many people have sang the stories at all?
A couple. That's great. They're very powerful and moving. The other piece of work is of particular interest to the Southern DHB has been the Dunedin Hospital rebuild, and that is now at the stage of becoming a Dunedin Hospital new build, and planning for that. The Community Health Council has been receiving regular updates from Dr. David Perez, who heads the clinical leadership group. So he's been keeping us informed of what has been proposed as those ideas have emerged. And we were very active as a council in giving some feedback on accommodation needs for people within the Southern Health System. So accommodation needs, sometimes people focus, and it's really important, of course, to focus on the family of sick children, but our region's quite unique in that we have 320,000 people spread throughout the largest geographic DHB in the country. A really big spread, and actually sometimes the accommodation needs are going to be for the family members of, you know, an elderly person from Tuatapere who needs family here in Dunedin to support them while they're in hospital. So we made a number of recommendations around accommodation considerations needing to stretch beyond those of family of younger people to family and support people, full stop. We also have members of, so our council are 11 people, and a lot of people are involved in many of these different activities. Kelly Takarua, for example, is involved in the Sexual Health Governance Group. We're involved in the emerging Choosing Wisely program, which is about having discussions about, is this treatment or is this medication the most appropriate one for me, and what are my alternatives, having those conversations. Leslie Gray has just done a sterling job of ensuring that letters that are coming from, particularly from the DHB, out to people. Perhaps these are letters around you were booked to attend an appointment and the date of that is now needed to change and we're not going to be able to see you within the time frame we originally anticipated. Leslie has done a lot of work to make sure that that information is clearly and caringly communicated. And so I think it's a really good example of where advisors to the healthcare system can really make a difference. So, you know, we might not be, you know, all health professionals, we're certainly not working in the system, but actually thinking about what is receiving a letter like this meaning for someone who's sitting at home waiting for their appointment, or they thought they had a date for surgery next month and now they find out that due to unforeseen circumstances that's been delayed. What's it like receiving that letter? Well, Leslie very much has been working to ensure that those letters are vastly improved, and she's rallied a team of people from her community to help her with that. So a retired English teacher and various friends have been working on that piece of work. And similarly on patient-focused bookings, so Leslie is very involved in that. And the idea behind patient-focused bookings is eventually that people will be able to go in and schedule their own appointments at times that will suit them, that fit in with their work schedule or family schedule. Other activities have been, ILCA sat on there was quite a significant review of the third floor surgical services. People have been involved in, you'll be aware there's been a major sort of restructuring at the DHB, and Community Health Council members have been sitting on those appointment panels. And similarly giving feedback into a workforce development strategy in terms of thinking about new and interprofessional ways of working. But what we're really wanting to touch on today is this big piece of work that's been occupying all of us around how the DHB and PHO can effectively engage with people as advisors to the healthcare system, and developing a strategy for actually implementing that. And also we've been developing resources to support staff, community, whānau and patient advisors. So we had a Community Health Council day-long retreat where we looked at the resources that would be needed for staff and the resources that would be needed for people who are advising people within the healthcare system. Some of you who attended our November meeting will have seen an earlier version of this, which is a one-page summary of what we're hoping will come out of the engagement framework, so that instead of information being received, so the DHB communicating to the public that this is something's going to be happening, or even consultation where there might be one-off meetings. I mean, the primary community and primary care strategy was a good example of that, where there were a series of meetings held around the region to discuss that, to consult and get feedback, but actually to move from those information and consultation ends of the engagement framework through to genuine partnership, collaboration and empowerment of communities. So we are very much focused on wanting the work to end up in that part of the engagement framework, so that we're not just being consulted about decisions that are already made, that as members of the public, we're involved early on, or representatives are involved early on in that decision making. Is there anything else I should be mentioning there, Charlotte?
No, I think that's...
Yeah.
I think behind this sits another document though.
Oh yeah.
Which will go up on the website eventually, but it just goes into more detail. There's a document that sits behind this that goes into more detail, which will be put up on the website when it's completed.
So I was talking to a family member about this engagement framework and why it really matters. So as a community health council, we think that there are some exciting potential benefits from us getting involved in improving our healthcare system. And had quite a challenging conversation with this family member actually, like, what do you mean by engagement? What does it look like? How will the general public even know what you're saying? Like, we know as a council because we've been immersed in this for a year, but actually, what does it look like? What does it really mean? How can you make this even tangible? Like, I don't understand what you're talking about, and I've been listening to you talking about it for a year. So I think maybe one of the ways in which to give an example of how having advisors ready to engage in the system is, you'll be well aware of very adverse consequences that happened locally as a consequence of delays in the ophthalmology service. There were people who lost their sight as a consequence of that. And we were contacted very quickly by members of the ophthalmology service wanting community advisors to help them think about how to change and improve that system. So people with experience of the eye service, they wanted involved. And we really supported that. Yes, that's excellent and you absolutely need to do that. But we weren't able to respond to them with, here are the names of 2 or 3 people who've said that they would be interested in working to improve the system. We just weren't able to respond quickly enough. And those conversations are happening more and more and more. Our Community Health Council is receiving requests on an at least weekly, if not sometimes daily basis, wanting community, whānau or patients to be involved in improving services. And we can't be those people for all of the requests in a health system as large as we've got. And some examples of current things that are before us at the moment are Dr. Mike Hunter and manages the overseas theatres, and there's a big project around improving access to acute theatre space, and we really need advisors to be involved in that, and actually thinking about theatre even more generally. Another example would be Dr. Joe Mitchell from the rheumatology service is about to embark on a major redesign of how that service operates. Is tired of having people waiting long times in outpatient appointments, waiting way past the time of their due appointment. That needs to have a major rethink about how that service functions, and wants people from the community with an interest in that area to be involved to help contribute to improving that system. So those are some sort of practical examples of how we would like advisors to be involved in improving the health system.
I was just going to say, since before coming out to the community, we have also done a series of workshops with staff as well. So we're starting to sow the seed, I guess, this idea and concept around partnership with community members. So it will just grow, I imagine.
Yeah, and the timing is right for a number of reasons. So the Health Quality and Safety Commission is saying this needs to happen. The Ministry of Health is saying this needs to happen. And the DHB and PHO executive leadership teams are wanting this to happen. And so we think that the timing is right to have expressions of interest. And so the deciding who's an advisor or not is not up to our Community Health Council, but we would very much like to support the process. We would like to facilitate it by having a register of people who are interested in being available, and we would like to offer a mentorship process. We would like to be able to mentor people who are advisors, to support them, to encourage them that you're doing a great job, or if they're saying I'm not feeling as though I'm able to speak up in this group because there are a number of health professionals around the table and I feel I can't add anything, to reassure them that each of us are experts in our own health and experiences, and experts in what matters to our families, and experts in what matters to our communities. It's a different type of expertise, but it's very much an expertise. And it's one that hasn't been given due hearing, apart from a number of exceptions. So there have been mental health advisors working in mental health services for some time. And there are also advisors working in falls prevention. So there are examples of this working really, really well throughout the system. But this move to extend this to a much wider program of work throughout the health system is quite a significant change. So advisors can offer insights about what is working well and where things need to change. And I can certainly, I could talk at length about experiences I and my family have had in the healthcare system that have not been ideal, and also some examples where things have gone pretty well. But we can bring quite a different perspective on why, from our viewpoints, things are not working well and where things can change. We can also suggest priorities and improvements based on the needs that we know that the health system providers may not. And quite importantly, and we see this happening from our Community Health Council members all the time, we just have new ideas and new ways of thinking about problems that people who are embedded in usually very busy jobs working in the healthcare system just might not be able to lift their head above to see. We can help with that. And I've touched on this already, why health managers and professionals should be doing this, and why there's a commitment to do this. So, sorry, Charlotte. It also, I don't think I touched on how it directly relates to upholding the Treaty of Waitangi and multicultural obligations. That's actually required in legislation that our health system providers begin addressing the inequalities and inequities we're seeing there. And that's probably not happening. In fact, it's definitely not happening throughout the wider health system in New Zealand in a way that it should be. But it's also consistent with a number of health priorities nationally and the Health Quality and Safety Commission. And so what we're going to do is establish a register. So when the Community Health Council formed, there were over 90 expressions of interest for people to be members of the Community Health Council. And so Charlotte has already the beginnings of a register from those people who came forward saying they're wanting to engage. And we would like to improve and develop that register. We would like to provide mentoring and support to advisors, because we appreciate that sometimes it can be a little nerve-wracking being an advisor in a room that might have 6 or 7 nurses and physiotherapists and doctors around the table. We're also quite clearly saying for bigger pieces of work, for significant service redesign pieces of work, that we don't believe just one community whānau or patient advisor should be there, that it would be very important to have two people supporting each other in the room so people do feel more confident to speak out. We've been developing tools to support staff with engagement. As Charlotte said, we've begun the series of roadshows and staff training sessions throughout the DHB, and we've also gone to the PHO. The other thing that we'd really like to do is gather feedback both from people as advisors and from staff involved in projects about how it's worked or not worked and how we can improve it. So it's this continuous quality improvement cycle. And then we would like on at least an annual basis to have symposia where advisors or people who are interested in being advisors can come together to learn from each other in terms of what worked, what didn't work, what needs to change, and strategies that people found for overcoming difficult or challenging situations. And so what we're asking you to do is to help identify prospective community whānau and patient advisors. And it may well be that you would be really interested in being an advisor to the system. You may already be an advisor to the system, which is great. Do you know people who, or are you someone who can share insights and experiences, listens well and speaks up, and has an interest in improving healthcare for others? So those are the qualities that we're really looking for in advisors. People who are not shy of asking difficult and challenging questions, but also in line with those 5 principles, are really willing to work together to try and find solutions that are possible. What we're asking staff to do is also to look for opportunities to involve advisors. So staff will encounter a lot of people, you know, in their clinical roles that may be willing to come forward and be advisors to the system. And examples of advising could be just attending, not just, but could be attending a meeting to discuss their experiences. So staff might want to invite patients or family members in to learn about what worked and what didn't work in the experience of their service, through to perhaps providing feedback on policies, practices, information and resources. So all too often resources go out to patients and family members that are not well written, are not, the information is not clear and accessible to people in the community. And we, you know, involving us early on in the development of those resources can change things for much the better. It may also be that people are invited to present at staff orientations and in-service programs, to record their patient or whānau stories. We saw that example of Levi and his mother earlier. And then through to providing advice on bigger, much longer term projects. And I think the acute theatre issue and theatre more generally is one example of that, and the rheumatology service redesign is another. And people are actively wanting advisors to work on those projects now. And then, as I mentioned earlier, at the end of the process, we'd like feedback from you about what additional resources we could provide, feedback on the process and what could be improved. And how we can help is through the register that Charlotte is developing, establishing connections so that when the eye department staff, let's really hope this never happens again, but let's say there's an issue in a different department and they really want advisors urgently, that we're able to say, here are the contact details of 5 or 6 people who have expressed interest, please go ahead and contact them. And then you and they have a conversation, and you'll just, you know, then the project can get underway. So that's the position we want to be in. And we'll be doing ongoing resource development for both staff and advisors, and are available for general inquiries to help as a council. So as a council, we would really want to learn from all the advisors working in the system about how it can be improved. And this is just a summary. Have you got some hard copies of the roadmap? There's a few more here that I've printed out too, Charlotte. this information is going to be available on the Community Health Council website. So at this stage, the engagement framework and the roadmap for implementing it has been presented at the senior leadership teams, executive leadership teams, and to the commissioners, and has support and also a proposed schedule for reimbursement. Is that on the next slide? So we've been arguing from the outset that there needs to be recognition of our time in these engagement activities. So if it's the general public being invited to a meeting, then that might involve providing refreshments, and if we're notified that people are needing interpreters, then we can establish that, you know, the PHO or the DHB. A personalised invitation to a one-off event, though, will require a bit more support, like perhaps there'll be lunch provided if you've been invited to a workshop to really brainstorm ideas for how to improve a service or how to improve the communications that are going out to people, you know, in different programs. So there could, you know, could and should, we're recommending, be reimbursement for taxis or transportation costs if those are required for people to attend the meeting. And again, refreshments should be provided. But if people are going to be involved in ongoing larger pieces of work, these bigger policy development or service redesign pieces of work, then people should be, advisors working at that level should be reimbursed for their time, including any reading or preparation time for attending those meetings. And the recommendation is that if there was a meeting and up to a total of 8 hours preparation and meeting time, that would be reimbursement at $250, as well as reimbursement for travel costs and, you know, mileage and expenses like that. And this has been approved, as I said, by SLT and the executive leadership team through to the CEOs and the commissioners, but it's not been implemented yet. Yeah, but that is our recommendation, and that is what's been supported. So if people are asking this of us, there needs to be a recognition of the value, you know, of that contribution.